Good afternoon, everyone. Today I'll be talking about a pragmatic approach to acute kidney injury. So, today we'll talk about the epidemiology of acute kidney injury, the definition of acute kidney injury, its pathophysiology, diagnosis, and management. But we won't go into the individual causes of acute kidney injury or how acute kidney injury is managed dialytically. So, let's first look at the epidemiology. Why should we even bother about acute kidney injury? It's because it's common, preventable, and treatable, yet if not managed properly, it can result in death, chronic kidney disease, and dialysis dependence, all of which are catastrophic for those paying out of their pocket for healthcare. So the most common etiologies of acute kidney injury lie in the community, and medical causes form, the majority of these causes of acute kidney injury. The actual etiologies would vary depending on where the data comes from. For example, this study from North India found diarrheal disease, malaria, and sepsis as the most common causes of acute kidney injury. And you can see a very high mortality and need for dialysis. This is often seen in hospital-based acute kidney injury studies because you would select for a population that comes, that is sick enough to come to the hospital and get admitted. Now, this study from our own center, which was published in 2011, one of the highest ranked nephrology journals, was done as a joint project between the Department of Medicine and Nephrology, and looked at all those who were admitted to medical wards over a period of 1 year with an acute febrile illness. As we all know, scrub typhus is the most common cause of acute febrile illness here, unlike the north. And close to 41% of these patients had acute kidney injury, but you see a much lower requirement for dialysis and mortality, probably because this looked at all patients with acute febrile illness, and it's probable that patients here have better access to care and reach us earlier. But what's different about acute kidney injury in developing countries like India compared to, say, the Western world? One is that our patients are a lot younger. As a result, they have fewer comorbidities. This is a good thing in that they're likely to recover better from an acute kidney injury. But if they don't recover, this has a huge economic impact because they're often, economically productive members of society. And especially if they're the sole breadwinner, this can have, a devastating impact on their families. In terms of the etiology, as I said before, unlike the West, where a lot of the acute kidney injury is hospital acquired, our acute kidney injury is largely community acquired due to infections, hypovolemia, and various toxins. So we usually see a single cause, but sometimes it can be complicated by things like NSAIDs and herbal medications, which patients may have taken before coming to the hospital. Apart from these, there are some factors which are unique to the Indian subcontinent. For example, our hot and humid climate means most of our patients have a baseline level of hypovolemia, and we'll often see a prerenal component in most of the acute kidney injuries that patients present with. Also, the fact that we are endemically malnourished may have an impact on the type of infections patients may develop in hospital, and which may affect their morbidity and mortality. There are also logistic constraints. We often see patients reaching us too late, and as a result, having a more severe AKI than they would have had if they had reached us earlier. And also, in many parts of India, access to ICU care and dialysis is compromised. Before we go into acute kidney injury, it's very important to understand some, basic things about kidney function. So what does the kidney do? This is the basic functional unit of the kidney. It's called a nephron. And you can see that blood enters through the afferent arteriole, and an ultrafiltrate of plasma then enters into the tubule. So step one is, the process of filtration. In step two, the kidney reabsorbs whatever it finds useful, which is usually sodium, potassium, bicarbonate, glucose, amino acids, and water. And in step three, it starts to secrete waste products like urea, creatinine, and many of the organic acids that are formed as a result of metabolism. And ultimately, less than 1% of what was initially filtered actually makes its way out as urine. So it's a very efficient system. So you can imagine if anything goes wrong with the kidney, it would affect all of these functions. So apart from the fact that waste products are retained, there also be dysregulation of the extracellular volume and electrolytes and acid-base balance. Many people are confused by these terminologies. What is acute kidney injury and what is acute renal failure? Are they the same? Acute renal failure was a term which was used previously. It's no longer used. And the reason why we shifted from ARF to AKI is because we now know that even small changes in kidney function have a big impact on morbidity and mortality. So acute renal failure is really a subset of all those with acute kidney injury. And it's generally those patients who have a severe enough acute kidney injury to require dialysis. So it's a small subpopulation of AKI. It's better we don't use this term because it's often confusing. And I'll when we talk about the staging of acute kidney injury, you'll understand why we no longer use the term ARF. So how does one detect a loss of kidney function? We're all familiar with creatinine, and as I said before, because creatinine is excreted, when there is a loss of kidney function, less creatinine is excreted, and so creatinine in the blood would rise. Another way is to measure the GFR, say by doing a 24-hour creatinine clearance, or you could estimate the GFR using various equations that use creatinine. You may have heard of the Cockcroft-Gault or the CKD-EPI equations, which are commonly used. Another important indicator that not all is well with the kidney is the urine output. And this is much easier to measure in hospital than say at home. And it's something we all use routinely in clinical practice. But all of these have problems. And I'll go into this. So what's wrong with creatinine? If you look at this graph, you can see that for a large part, you can see a big fall in GFR. For example, GFR has fallen from 180 to around 60 without much change in creatinine. So creatinine is very insensitive in the early stages of a kidney injury. And thereafter, you will see a big jump in terms of creatinine, but the GFR hasn't fallen as much. So the problem with creatinine is that, first of all, it lags behind the actual changes in GFR. All right, so you would be late. If you looked only at creatinine, you would be late to pick up an acute kidney injury. In the early phase of acute kidney injury, the insult may have already happened and creatinine would start to rise only around 1 to 2 days later. So in the early stage, the creatinine may be much lower than the degree of injury that has actually happened in the kidney, and you would overestimate the actual GFR. The opposite happens when someone is recovering from a kidney injury. Creatinine takes time to fall. So it may take 1 to 2, urine output may start improving, but creatinine may start to fall only later. So you would actually underestimate the actual GFR in the recovery phase. It's also removed by dialysis. And so if you check the creatinine after dialysis, you'd think the kidney function is improving when actually that's not so. It's just been removed by dialysis. It also depends on muscle mass. So those who have a lower muscle mass, children, the elderly, women, those with chronic liver disease, it's difficult to diagnose acute kidney injury in them because creatinine values are often lower. It's also affected by hydration. So if, for example, if a patient came into the ICU, in the initial stage, they're always aggressively hydrated. And you may find that the creatinine may not rise if checked the next day because of the aggressive hydration. You may see a rise only later. So hydration affects the rise in creatinine that you would see if you measured it in blood. What's wrong with GFR? First of all, GFR is very difficult to measure directly. As anyone who has tried to do a 24-hour urine collection will tell you, it's prone with a lot of errors, and it's not really practical. And because if you try to use an estimating equation, all the problems that there are with creatinine are true for the equations that you use. So just as creatinine lags behind GFR changes, any GFR that you calculate using creatinine would also lag behind GFR changes. And the most important factor is that equations are only valid in steady state, and acute kidney injury is by no means a steady state. So really, there's no utility for these equations in acute kidney injury. You're much better off using clinical signs. What's wrong with urine output? First of all, patients often don't notice a decline in their urine output till very late. And at the same time, you would often see, for example, in the ICU that the output may be low for a couple of hours. You hydrate and the urine output improves. So transient fluctuations are not as important as, say, a sustained decrease in urine output. So that's important to differentiate. And if you paid attention only to urine output, you would miss out on this important entity called non-oliguric acute kidney injury, in which the creatinine rises, but the urine output remains normal. And this often happens with injury to the interstitium or the tubules. And also outside the ICU, urine output may be difficult. But creatinine and urine output are still our best bets in terms of the tools we have to diagnose kidney injury. First of all, creatinine is cheap, it's easily available and easily measured. And urine output, even if you're not able to monitor it hourly, you can monitor it shift-wise in wards, and patients can be taught to record their intake and output even after discharge. They just need to keep a diary of that, and so it's a low-cost way of monitoring. How should we define acute kidney injury? Now, there have been many definitions, but this is now the most widely accepted definition. It's called the KDIGO criteria, and that stands for the Kidney Disease Improving Global Outcomes criteria. So AKI is defined as an increase in creatinine of at least 0.3 milligram per deciliter within 48 hours. It's very important to know these time periods. So a 0.3 milligram rise within 48 hours, or a 50% rise within 7 days, or urine output that is consistently less than 0.5 ml per kg per hour for at least 6 hours. Any of these criteria would mean that the patient has an acute kidney injury. It's very important that this should only be done after the volume. This criteria should only be applied after volume status has been optimized and you have ruled out a urinary tract obstruction. So an ultrasound is important in any patient presenting with an acute kidney injury. So I had alluded to the fact before that we no longer use the term acute renal failure, and that's because we now, in order to indicate severity, we simply stage the AKI. So there are 3 stages of AKI, depending on how high the creatinine is or how low the urine output is. And as you can see, the higher your stage, the worse the AKI is. So if your creatinine has risen between 1.5 to 1.9 times within 7 days, or at least 0.3 milligrams per deciliter in 48 hours, you'd be in stage 1. If your urine output was low for between 6 to 12 hours, you'd be stage 1. If your creatinine rose to between 2 and 2.9 times, or your urine output was low for at least 12 hours, you'd move to stage 2. And any creatinine above 4, or a creatinine which had risen by more than 3 times from baseline, or a requirement for dialysis, or anuria for 12 hours, or urine output less than 0.3 ml per kg per hour for at least 24 hours would indicate that the patient had reached stage 3, which is the highest stage of acute kidney injury. So the prognosis, the chance for recovery from AKI, and the requirement for dialysis would of course increase as you progressed along the stage of AKI. Now, there's some confusion regarding which is more important. Is the urine output criteria more important, or the creatinine criteria more important? Now, first, it's important to know that when you use the urine output criteria, you should use the ideal body weight of the patient. Okay, that's important to know. And in a patient who's receiving diuretics, the urine output criteria may be erroneous. And also, the a cutoff of 0.3 ml per kg per hour is more predictive of an AKI than the 0.5 ml per kg per hour. So patient in the ICU, very often we found that at that 0.5 ml per kg per hour stage, it may still be reversible with some hydration, right? But death and dialysis requirements are definitely highest when a patient meets both criteria. However, if only one of the criteria are met, or there is some dissonance between the 2 criteria, use the criteria which results in the patient having the least favorable stratification. Okay, so that's a basic tenet of diagnosing and prognosticating AKI. What are the problems with this diagnostic criteria? First of all, although it helps you diagnose the AKI, it doesn't give you any information about its etiology. And we know from clinical practice that often the prognosis of an AKI depends on what caused it in the first place. Also, we require a baseline creatinine. This is often a problem when patients come to us first. They may not have a baseline creatinine. So some people have said that you can try and back calculate a creatinine, assuming that every patient has a eGFR of 75. Now, obviously, there's a problem in this because a patient may have CKD. So, I mean, no one really does that anymore. You can use your admission creatinine, the first creatinine you have in the hospital, as your baseline value, and then check serial creatinines, but you'd have to wait 48 hours to diagnose an AKI. If you did have any prior value within the last 1 year, you can take an average of that prior, and use that as your baseline creatinine. But yes, this is one of the shortcomings, the fact that you need a baseline creatinine to make this diagnosis. The second thing is that the higher a patient's creatinine is, there's an individual variability in creatinine, and the higher your creatinine is, the more variability there is around normal variability there is around this creatinine value. So above a creatinine of 1.5, and as you go higher, the variability may be as high as 30%, just normal variability. So how it becomes difficult to diagnose AKI when creatinine measurement itself has that much variability. So this is important, especially in patients who have an underlying CKD, because they would have a baseline higher creatinine, and you would see a normal fluctuation in them, which may not actually be an AKI. So a creatinine of 0.3 moving in, 0.3 increase in a patient with a CKD may not actually mean an AKI. It may be a normal variability. And of course, keeping a cutoff of 0.3 milligram per deciliter means that nephrologists will get called a lot more often than before, but that's part of our job. Right, but the utility of this criteria is that it helps to prognosticate a patient in terms of their mortality and the length of ICU and hospital stay. And definitely they've helped to create a uniform criteria for use in epidemiological studies and as endpoints in trials. So that's their utility. Now, I'm sure a lot of you are asking, what about biomarkers? Now, I'm not a big fan of biomarkers, and this is the reason why, because there's a whole lot of them. And every study will give you, different findings, different cutoffs, and it only, in my opinion, just increases confusion. But this is the lowdown on biomarkers. So far, the only advantage that biomarkers have is in AKI prediction or prevention. This is the utility. This is the use for which there is the strongest evidence. The evidence for their use in diagnosis, in looking at the severity, etiology, management, need for dialysis is much, much weaker. The other important use is in drug dosing, and here a combination of the CKD, EPI, and cystatin EGFR equation has actually been shown to be quite useful. And of course, biomarker studies are always published, whether or not this give you any useful information. But the disadvantages are that they're expensive, they're not easily available, especially in a country like India. Every study has a different cutoff. And the level of a biomarker may be affected by a patient's comorbidities. We definitely know that they're not useful to assess the risk of an AKI before the insult. And really, their predictive value depends on the study population, and clinical models routinely perform better than biomarker-based models. So in my opinion, they're not really of much use in our setting. However, there is now a move to use biomarkers to further prognosticate patients using the existing criteria. So the proposal is, this has not yet been accepted, but the proposal is that for every stage of AKI, if you have a biomarker positive, you would move to a higher stage within that AKI. So in stage 1, you would be stage 1A if you are biomarker negative, but 1B if you're biomarker positive. And there's also a proposal to have an even earlier marker of AKI, which would be called 1S, in which only a biomarker was positive and neither creatinine nor urine output had budged. So, well, there'll be a lot more work for nephrologists and a lot more income for hospitals if this comes into play. Anyway, so just to consolidate on what we've learned, which of the following would suggest an acute kidney injury? Someone who has a current creatinine of 4, but a creatinine 1 month ago was 0.6. Someone who had a creatinine of 4, but 1 year ago creatinine was 2. Current creatinine of 4, creatinine 2 days ago 1.5. And someone who is a day 2 post cabbage, weight 50 kgs, current serum creatinine 0.8, yesterday's creatinine 0.6, urine output low for 4 hours, and we have a biomarker being positive. So as you would have noticed, we have a baseline creatinine value in the first case. You can take this as your baseline creatinine value. This can suggest an acute kidney injury. But if you have a creatinine 1 year ago being 2, this is obviously someone who has a chronic kidney disease. So this may be an acute on chronic kidney disease, or it could be a normal progression of chronic kidney disease if we don't have any intervening values. This is definitely an AKI because within 48 hours, it's more than doubled. And here, it doesn't fulfill the classic criteria. So it's it's moved by 0.2. Urine output has only been low for 4 hours, but there is a biomarker being positive. So if you use the if you subscribe to the latest classification, this would be a very early stage of acute kidney injury. Right. Now let's look at pathophysiology, which is important to understand because it helps us in managing our patients. So the kidney is divided into different compartments, and the causes of a kidney injury can be understood based on what compartment of the kidney is affected. So in pre-renal kidney injury, it happens because blood flow to the kidney is compromised for some reason, either because of hypovolemia or cardiac failure or hepatorenal syndrome, in which the kidney vessels basically go into spasm. Okay. Any a thrombosis or occlusion or a vasculitis of the renal vessels would lead to a vascular cause for acute kidney injury. Small vessels of the kidney could be affected in vasculitis or a thrombotic microangiopathy. Glomerular disease is an important cause. Next come the tubules, and this is what we most commonly see in hospital. Acute tubular necrosis is often what patients come with as a result of ischemia or various toxins. Interstitial nephritis is commonly caused due to drugs. And sometimes the tubules may be obstructed by casts, for example, in rhabdomyolysis or in drugs, like acyclovir. And post-renal causes are usually due to some mass or lesion in the urinary tract. So in prerenal acute kidney injury, basically there is decreased perfusion to the kidney. And this results in the renin-angiotensin and the vasopressin system and the sympathetic nervous system getting activated. And all they try and do is somehow try and maintain blood flow to the kidney. What they do is therefore to vasoconstrict, because they want to maintain the perfusion pressure. They cause vasoconstriction and try and reabsorb salt and water. Okay, so what this does is that therefore the urine output will drop. Along with the salt and water, you will find urea also being absorbed. And that's why you'll find in pre-renal acute kidney injury, you'll find a disproportionately high urea because, along with the water, urea is also, absorbed. Okay, and therefore urine also becomes more concentrated. You'll have a small volume of concentrated urine. Okay, and although there's no point in measuring sodium often because we often don't get the time or the mental space to order it, you would find a low sodium because again the kidney is holding on to the sodium that it has, right? So this is what happens in pre-renal acute kidney injury. You'll have a disproportionately high urea and you'll have a small volume of concentrated urine. So this is what is actually happening when perfusion to the kidney comes down. The kidney somehow wants to maintain its perfusion pressure in this range. In order to do that, it will either, it will try and constrict, constrict vessels. So what happens here is prostaglandins are basically hormones which would be vasodilatory. Okay. Now, what happens when you take an NSAID? An NSAID would block a prostaglandin secretion and therefore cause worsening of vasoconstriction. That's how NSAIDs worsen a pre-existing acute kidney injury. Okay. ACE inhibitors and ARBs work at the opposite end. Okay. What angiotensin 2 does is angiotensin 2 tries to constrict here. By constricting here, it increases pressure behind it and allows urine, the filtration to continue. But what ACE inhibitors do is they dilate this. When this gets dilated, pressure here drops. So urine output and GFR would drop. Okay, so this is how both NSAIDs and ACE inhibitors will actually predispose to acute kidney injury in someone who already has an insult. Okay. And there are a group of patients who are especially prone to prerenal AKI. These are those in whom there is an impaired autoregulation, either because of chronic kidney disease or because they're elderly or have diabetes or hypertension. This is the group in which you would often see that even with minor fluctuations in blood pressure, you may find that they sustain an acute kidney injury. Okay. Right. Okay. Now let's move from prerenal to intrinsic renal, the glomerulus. I won't go into too much detail, but you would have heard of two important syndromes, the nephritic and the nephrotic syndrome. In the nephritic syndrome, you would find glomeruli which are really angry, full of inflammatory cells. All the capillaries are closed up. And because of this, because the capillaries are all closed up with inflammatory cells, the surface area available for filtration drops, and this automatically leads to a fall in GFR. And obviously then salt and water would be retained. The damage to the basement membrane means that RBCs and proteins start leaking into the urine, and this is what we see as casts, RBC casts. All right. Nephrotic syndrome is different. You see a lot of protein leak, and because of severe proteinuria, you would find hypoalbuminemia. Because of hypoalbuminemia, there's a loss of oncotic pressure. Because of a loss of oncotic pressure, there's third spacing of fluid, and this causes intravascular volume depletion. Okay. So the reasons why they cause acute kidney injury are slightly different. But what we most commonly see in the hospital is acute tubular necrosis because of various causes. It's important to understand what is happening here. In any of these insults, the tubular cells undergo various degrees of damage. In the earliest stage, what happens is that there is the normal transporters start moving, so there's a they if they're on the basolateral membrane, they'll move to the surface, and if they're on the surface, they'll move to the, basically they just move around, and as a result their functions go awry, right? So, and the second thing is, of course, that the normal brush border which is required for reabsorption, all that is lost. Okay, so as this degree of injury increases, these cells start losing their connections between each other. So first they lose polarity, then they lose their connections from each other, then they start falling into the lumen and start blocking and form casts. So once they form casts, of course, urine can't go through, right? So there's this phenomenon called tubulo-glomerular feedback, because the question people ask is, when only tubules are being affected, why should the GFR drop? Because the filtration is taking place in the glomerulus, and this is the answer why. Okay, so what happens is that there's a part of the tubule called the macula densa, which is very sensitive to chloride especially, and chloride obviously moves with sodium. Okay, so if you have a situation where, so what is actually happening here is sodium would not, so the sodium potassium ATPase would normally be here, but now it moves over here. Okay, sorry, it moves here, and as a result sodium would start leaking into the tubule, because that's what this transporter normally does. Now, this is sensed by the macula densa as more sodium and chloride coming into the kidney. And what the macula densa does when it senses more sodium and chloride in the filtrators, immediately causes vasoconstriction. Even though there is actually no decrease in perfusion, it is sense increase in increased delivery. Even though actually there is no increased delivery, it's just because of a malfunction of the tubules. The macula densa thinks that there's a lot more sodium and chloride reaching it, and it starts to cause a vasoconstriction. So this functions almost like causes a fall in GFR. Okay, so this is how a tubular injury, by causing feedback, can cause a fall in GFR. Okay, apart from that, like I said, when tubules are blocked with necrotic cells, that also would cause, obviously, because urine just can't come out. Okay, now it may actually be protective, because the fact that the tubules start shutting down means they will use up less oxygen, and this actually allows these ischemic tubules to slowly recover. So it may be the body's protective mechanism, but of course it leads to greater dialysis dependence, because patient would be oliguric at this point. Right. Acute interstitial nephritis is another cause for acute kidney injury, usually due to drugs, especially drugs like the penicillin group or sulfonamides. And this is what happens generally, is that it's usually an acute, it's usually a non-oliguric acute kidney injury. This is classic of of interstitial nephritis. Often you won't have a decrease in urine output. The classic triad that people have described of a fever, rash, and eosinophilia is more common with penicillins. You may not see it in a lot of drugs, and it's generally because these drugs are somehow cross-reacting with antigens present in the tubules. It's important to diagnose it, take away the offending, discontinue the offending drug. And if it's still not improving, a short course of steroids may help. Post-renal acute injury, most people are familiar with. It's because of an obstruction. What is important is that damage to the kidney happens within almost 24 hours of the obstruction developing. So time is of essence. When you see an obstructive AKI, it's very important to relieve that obstruction, because the longer you wait, the more tubules are getting damaged and the more likely that the patient would have residual damage which does not recover. Okay. So how do you assess the patient? The most important thing is to take a proper history, because this may give you clues as to the etiology. Ask about any risk factors and exposures. And you're trying to basically find out what type of AKI it is. What is the etiology? Was this community acquired or hospital acquired? Is this really an AKI, or is it actually an AKI on CKD? Is this patient's urine output low? How severe is this? Has this patient developed any complications? And do you think this patient needs dialysis? So the aim of a history is to answer these questions. So in risk assessment, these are important things that would make a patient susceptible to an acute kidney injury. And these are important exposures: sepsis, shocks, burns. These are the type of exposures that when you know a patient has been exposed to this, you can expect that this patient, especially with underlying susceptibilities, the combination of having a susceptibility and having an exposure would put a patient at a much higher risk of developing an AKI. So it's important to familiarize ourselves with these susceptibilities and exposures. So in someone who you know is high risk, it's important to daily measure creatinine and urine output while in hospital, because this offers you a window to diagnose AKI early. So how do you narrow down the possibilities on history? So if you have a history of diarrhea, vomiting, bleeding, or diuretics, or a situation like chronic liver disease, CHF, or nephrotic syndrome, where actually patient may appear hypovolemic, but the kidney is getting hypoperfused, you can think of a pre-renal etiology. Unlike that, if you have a clear-cut history of hypertension, hematuria, edema, or connective tissue disease, disease symptoms, think of a glomerular cause. If you know that the patient has had a prolonged hypotension, some drug or sepsis exposure, think of an ATN. If you have a classic history, or especially of a drug that you know can cause interstitial nephritis, and the patient is non-oliguric, think of an interstitial nephritis. Post-renal patients usually present either with a suprapubic distension or difficulty in voiding. And if the obstruction is higher up, they may present with loin pain and or hematuria. Never forget to take a proper drug history. This is especially important in our country because medicines are so easily available over the counter. So you must take a complete drug history and take a travel history, because many infections are caused, are related to the travel history, and infections like leptospirosis may be linked to a patient's occupation. So take an occupation history. Then look at the patient. Do their eyes look sunken and pale? Is their tongue dry? Look at their JVP. All this will help you assess volume and help you rule out a hypovolemic AKI. Then look at their extremities. Cool, clammy extremities would point to a patient who's in shock. Rapid thready pulse, postural fall of blood pressure. Examination of the heart can help you decide whether the patient has a CHF. This is all, basic clinical examination findings that you need to pay attention to. Hypertension and the presence of a periorbital edema, some signs of a systemic disease may point you towards a GN. Look for a rash, for interstitial nephritis, and very often the history may suggest the reasons for an acute tubular necrosis. Very important to look at the bladder, especially in the elderly. A palpable bladder means you absolutely must put in a Foley's image, find out what's happening. Renal angle tenderness may point to a stone or a mass causing obstruction. Palpable kidneys, and it's very important, especially in the elderly, to do a pelvic or a rectal exam, because this may be one of the reasons for an obstruction. There are, like I mentioned before, a lot of the signs and symptoms are common to all acute kidney injuries. So the accumulation of waste products will cause nausea, vomiting, anorexia. Accumulation of fluid will cause edema, and patient may have basal crackles and a raised JVP. Patients with hyponatremia may present with an altered sensorium. Hyperkalemia may present for the first time with a cardiac arrhythmia, and patients may have an acidotic breathing if they're severely acidotic. This is, just an interesting thing. I thought we could take a breather. And this is actually a carp, and a very rare cause of acute kidney injury seen in central India, especially Jharkhand, Chhattisgarh area, where the gallbladder of this fish is consumed as an aphrodisiac. And it causes a severe acute kidney injury from which most patients do not recover. It's a very rare cause, but has been described. Right. So how do we diagnose acute kidney injury? So of course, the blood urea and creatinine would be raised, but especially if you see a urea which is much higher than the creatinine, think of a pre-renal cause. But other things you need to pay attention to are a GI bleed, because the blood in the gut is broken down and urea is reabsorbed from the gut. You must always make sure patient is not bleeding from somewhere over and above a pre-renal. Hypercatabolic patients, you often see this in malaria, or patients on steroids may also have a urea much higher than the creatinine. If the creatinine is much higher than urea, think of rhabdomyolysis, because creatinine would be released from muscles. Sodium may move up or down depending on the patient's volume status. Potassium is usually raised. Calcium again is variable, but a low calcium, you should think of two important causes, the rhabdomyolysis and a pancreatitis. Phosphorus is usually high because phosphorus is excreted, so any kind of injury would raise the phosphorus. Urine sediment is very important to look at, and if you have dysmorphic RBCs, you must think of a glomerular cause. If you see muddy brown cast, this is because of tubular cells that have fallen into the lumen and forming these casts. You should think of an acute tubular necrosis. RBC casts point to a glomerular disease, and WBC casts are seen in either an interstitial nephritis or a pyelonephritis. There's a particular test you use to look for to make a diagnosis of acute interstitial nephritis, and that's called urine eosinophils. We use either a Wright stain or a Hansel stain to stain for eosinophils in the urine, and more than 1% would suggest an acute interstitial nephritis. But make sure patient is not having a UTI, because that can also cause this. A patient who's been administered contrast may also have eosinophils in the urine. So these are important things to rule out before you make this diagnosis. Ultrasound is so important, as I mentioned before. It helps you to rule out an obstruction, and also it'll give you an indication if the patient has an underlying CKD. So if the kidneys are small in size and there's a loss of corticomedullary differentiation, it will actually tell you that this may be a CKD on which an acute kidney injury may be superimposed. All right, so people talk a lot about the fractional excretion of sodium. Frankly, it's not practical. We just don't use it in routine practice, but you may be asked this in the exam. So fractional excretion of sodium is just the proportion of sodium that was filtered that actually ended up being excreted. And as I told you before, in a pre-renal acute kidney injury, the body is trying to retain sodium. So obviously you will have very little sodium being excreted in the urine. So a value less than 1% points to pre-renal, and a value more than 1% is suggestive of tubular necrosis, because sodium is lost in the urine because the tubules are not able to retain the sodium. Okay, this is an important test. They'll ask you about how to distinguish between pre-renal and ATN. The problem with this is that if your renal perfusion is low with intact tubular function, you may have the same findings. So frankly, it's non-specific. At the same time, if you use a diuretic, because that helps to excrete sodium, a patient may have pre-renal AKI, but you would think because of a high fraction excretion of sodium that they would actually have an ATN. So in these situations, it's not really useful. Likewise, urine spot sodium, it would be low in pre-renal because the kidney is retaining its sodium. It would be high in an ATN. Again, it would be affected by diuretics. Well, fractional excretion of urea is believed to have an advantage over fractional excretion of sodium in those on diuretics, because it's less affected. So a value less than 35% may indicate a pre-renal AKI. Again, none of this is really used in practice. High urine osmolality points to a pre-renal cause. Like I said, the urine is more concentrated, and a failure to concentrate urine would be seen in acute tubular necrosis. Okay, right. Other important tests are presence of neutrophilia would point you towards the sepsis. Thrombocytopenia, think of a thrombotic microangiopathy. Eosinophilia, think of an interstitial nephritis. Low calcium, as I mentioned before, think of tumor-lysis, rhabdomyolysis, pancreatitis. High calcium, on the other hand, think myeloma. And often in the recovery phase of rhabdo, you may see a high calcium. If you have anemia and an AG reversal, please order a serum electrophoresis. Often patients may present for the first time with an acute kidney injury due to cast nephropathy. And if you think you're dealing with an acute GN, the next steps are to do a urine protein and routine serology. And it's the other thing to note is that if a patient's urine protein is positive and a patient has an acute kidney injury, this automatically tells you that this patient is less likely to completely recover from an acute kidney injury. It means that the patient already had an underlying degree of renal, chronic kidney disease. Okay, so that's an important marker of non-recovery from AKI. All right, so this is just summarizing everything that I've talked about before. What you would look for in history in terms of urine output, examination, and many of these tests in order to distinguish between pre-renal, post-renal, and ATN. The most important test really is this response to volume depletion. Okay, this is often the most important test for you to do clinically because a pre-renal will respond with an improvement in urine output and the others will not. Okay, so practically this is what we do in the wards, right? The other important thing for you to know is this AKI or CKD? Okay, so CKD usually has a longer duration of symptoms. Patients are usually not oliguric and the patient looks the investigations look a lot worse than the patient. Patient will look quite, stable unless they are of course in, encephalopathy or they have pulmonary edema. Nocturia is a very common predating history which you must take, all right? And the ultrasound will show you that this patient probably has a chronic kidney disease. The patient usually has anemia because of EPO deficiency. And PTH is an important test to order. If your PTH is high, this points to a chronic kidney disease. So this is simple clinical things, pointers to a chronic kidney disease. We generally do not biopsy patients unless they have an AKI which is dialysis dependent for more than 2 weeks, or if we suspect that the patient has an interstitial nephritis or a glomerular disease, or if there is some sign that the patient has a systemic disease, like a connective tissue disease, in which again we think probably we are dealing with the glomerular disease. And if you did a biopsy in a patient, this is what an acute tubular necrosis would look like. You see the cells have all necrosed and they're fallen into the tubules. And this is a very sad form of AKI. It's called cortical necrosis, in which the injury to the kidney has been so severe that the entire architecture is lost. These patients never recover their kidney function. In India, this is often seen in women with postpartum hemorrhage or abruptio. It's also seen in patients with snake bite envenomation. These are the common settings in which we see this kind of severe kidney injury. Now let's move to management. It's very important for you to assess volume status at admission because this is something eminently reversible. And thereafter, please monitor blood pressure, urine output, check daily weight. This gives you an indication for their volume status. Okay. If someone's weight is increasing and output is not increasing, that means they're retaining water. And this is a patient who will go into pulmonary edema if you don't either give them diuretic or don't dialyze them. So it's important to check their weight daily if they're not opening up. Make sure the patient is neither hypoglycemic nor hyperglycemic. Ensure the patient is not hypercatabolic by giving them enough calories. There's no point restricting, their protein intake at this point. And preferably try and give them their calories via the enteric route. Where required, please use the routine anti-hyperkalemic measures. You're all aware of what they are. And please treat metabolic acidosis. There's something that all of you should be aware of, and that is that very often in the casualty, when a patient comes with hyperkalemia, you would rush in, you'd give calcium gluconate, of course, but you'd also start insulin and glucose. Now, what happens if we try and dialyze a patient after that is that what insulin does is it pushes potassium intracellularly, all right? And it does lower potassium. But then when we try and remove potassium by dialysis, there's less potassium in the blood for us to remove. All right, so we finish dialysis, and then a few hours later, you will phone us telling us that the potassium is high again. And it's not that there was a problem with dialysis, it's because we created a gradient through dialysis whereby the potassium that had moved into cells has now moved out of the cells and back into the blood. So always remember this. If you've given glucose insulin, prior in casualty or in the wards before we dialyze, the potassium removal by dialysis will be less efficient. It's an important thing to remember. Okay. Metabolic acidosis. Generally, we say not to give sodium bicarbonate unless the pH is less than 7.1 and stop when the pH is more than 7.2. The reason being it can contribute to volume overload, especially if the patient is oliguric. Okay. Follow the ionized calcium because the total calcium is often affected by pH and albumin. Generally, don't treat unless the patient is symptomatic. And generally, phosphate, which is high, can be managed with calcium-containing phosphate binders. But if someone is having, symptomatic hypocalcemia because of a very high phosphorus or very severe hypophosphatemia, it's just better to do dialysis rather than use a phosphate binder because phosphate binders take time to act. So pre-renal AKIs are best managed with simple volume replacement, and these are tests that all of you are familiar with: IVC collapsibility, the PLR, and pulse pressure variability, which can tell you that a patient is volume depleted. And these are the endpoints all of you are aware of. You need a good enough map. If you're replacing volume adequately, your urine output should improve. You should begin to see an improvement in the blood lactate and a rise in CVP. Where required, please give blood products and vasopressors. Right. If there is no response to volume replacement, this is a volume unresponsive AKI. And here is where the controversy lies, because it's very important at this point to stop giving any more volume, because any more volume you give at this point will only increase fluid overload, increase your time on ventilator, and increase mortalities. So once you are sure clinically that the patient is adequately volume replaced and the patient is still not improving output, please stop any further aggressive volume replacement. And this is where the opinion differs. Should you give a diuretic at this stage or should you start renal replacement therapy? So there is something called the Furosemite stress test, which can predict the requirement for dialysis. So this involves giving a bolus of 1 milligram per kg in a patient who is diuretic naive, or 1.5 milligram per kg in those who've been on diuretic in the last 1 week. If a patient puts out less than 200 ml of urine in 2 hours, okay, this would be called furosemide. They would have failed the furosemide stress test. This means they're unlikely to respond to diuretics. Please proceed towards, dialysis. Okay, but of course the problem here is you can't. People have criticized how you can use a blanket value of 200 ml, urine, regardless of a person's, size or age. So there is something called furosemide responsiveness, in which you look at the 2-hour urine output and divide it by the furosemide dose that you get. So a value of less than 3.9 ml per milligram would be more predictive of dialysis and death. Okay. So what are the advantages? Of course, diuretics will prevent fluid overload, and they may help to flush out casts, and because they block the active transporters in the kidney, they may reduce oxygen consumption. These are the reasons why people use diuretics. Mostly it's to prevent fluid overload. The others are mainly semantics. But the fact is that diuretics do not prevent AKI. They do not have any effect on the severity of AKI. And they definitely don't reduce the requirement for dialysis. Those who need dialysis will need dialysis, whether you give them diuretics or not. All it does is it delays dialysis. And sometimes that may be worse for the patient, delaying dialysis. Okay, they may cause volume depletion and they may not haste recovery. All it does is it may buy you time, right? So use diuretics for fluid overload, but don't use it to convert an oliguric to a non-oliguric AKI. You have not done the patient any favor. Okay, so it's important to first of all find out what the cause of the AKI is, and then don't delay dialysis unless you're using diuretics in a patient with fluid overload. And like I said, if the patient is not responding to the stress test, please don't delay, move towards dialysis immediately. I won't go into the details of managing many of these. GNs are basically managed with steroids, And interstitial nephritis, as I said before, you have to stop the drug and you may give a short course of steroids. Postrenal AKIs are managed by relieving the obstruction, but it's important that after relieving the obstruction, you monitor these patients very carefully, because they have what is called a post-obstructive diuresis. They'll suddenly start pouring out urine, okay? You need to, at this point, measure their hourly urine output and daily weight. And because the tubules have lost the ability to concentrate, they start losing a lot of salt and electrolytes in their urine, okay? So they actually start, the fluid they lose is a hypotonic fluid. They're not able to concentrate their urine. So the replacement fluid should not be normal saline. It should actually be N/2 saline. If you don't have N/2 saline, you can alternate normal saline with dextrose, alternate bottles of dextrose and normal saline. Please watch for dehydration, because in a patient who's recovering from an AKI, you may cause what is called a tandem AKI, one AKI on top of the other, simply because you didn't manage their volume status during this phase of aggressive diuresis. So what would you monitor in a patient with AKI? You'd monitor their weight, their intake output, their blood pressure, and any signs of either overload or depletion. This is what you need to look at every day when you see the patient in the ward. In terms of investigations, electrolytes are important to monitor. Please do not check creatinine in a patient who's been dialyzed. Okay? Creatinine should only be checked in a patient whose urine output is improving and the patient is off dialysis. You are simply trying to look at improvement in creatinine. If a patient is not putting out urine, don't expect the creatinine to improve. So till the patient opens up their kidney, don't check a creatinine. It doesn't help at all. Once the patient starts improving urine output and the patient is off dialysis, then start checking creatinine. Otherwise, it's just a waste of money. Okay. When should you start renal replacement therapy? These are what we would call hard indications. A hyperkalemia, potassium rapidly rising. For example, you may see this in tumor lysis, or hyperkalemia not responding to your conventional measures, fluid overload not responding to diuretics, severe metabolic acidosis, hypovolemia, a patient has got pericarditis, encephalopathy, and any acute poisoning, with AKI, you should, and many acute poisonings, even without AKI, you would use, dialysis if they can be removed by dialysis. Okay, but often these are late indications. Okay, the trend now is to think of dialysis as renal support rather than renal replacement. So the trend is now to start it earlier in the phase of AKI rather than wait till the kidney is completely shut down, because by then the kidney injury is also far less reversible, than if you had started it earlier. The goals, once you start renal replacement therapy, the goal is that you want to maintain the patient in the best possible balance for their electrolytes, their acid base, and their fluid. You want to ensure they don't have any further insults to the kidney. This allows the kidney to recover. And at the same time, you keep supporting the patient with antibiotics and nutrition. All right. How much renal replacement is required? Again, like I said, you want to just give enough dialysis to achieve balance for acid base, electrolytes, nutrition, and fluid balance, but ensure that that the patient is not hemodynamically unstable. Now, if during dialysis the blood pressure drops, you would have caused another injury to the kidney, and often you may find that recovery is delayed in these patients who have hypotension during dialysis. All right. If the patient's output is improving, their potassium is stable, volume status is stable, you can withhold dialysis, then start monitoring, and then decide whether further dialysis is required or not, depending on their progression after that. How does ATN recover? So slowly what happens is these cells which have become necrosed will start multiplying again. So in a very early kind of injury, recovery may happen as soon as 3 to 5 days. But if you've had severe injury like this, where cells have necrosed and fallen out, the recovery may be delayed for up to 7 to 21 days. All right. So what should you watch out for in the recovery phase? Remember that because tubular function lags behind urine output, so urine output will start improving, but the tubular function is delayed. They may not be able to hold on to their water and electrolytes. Okay, so it's very important for you. That's why you have to keep monitoring output and electrolytes. Okay, and at this point, the kidney is very susceptible to any further insults. So avoid any hypotension, any further fever or nephrotoxic drugs. Okay, and do not discharge till the diuretic phase stabilizes. If you're pressed for beds, the best thing is discharge the patient, but tell them to keep a strict intake output chart. And you can ask them to check their urea creatinine electrolytes every 2 days, and they can follow up with you on an outpatient basis. But it's so important that they replace what is lost. Okay. So what is the outcome of acute kidney injury? Unfortunately, because patients reach us late, less than 50% would actually recover kidney function. And apart from death, those who do survive land up with hypertension, proteinuria, and chronic kidney disease, especially if they were elderly, already had CKD, had comorbidities, and had an AKI which was severe enough to require dialysis. But remember that even minor AKIs are actually bad. So even those with minor degrees of CKI who had almost recovered their normal kidney function, they had an increased risk of CKD within 3 years when they were followed up. So even after a patient recovers from an AKI, these patients should be kept under regular follow-up, and their blood pressure, proteinuria, and creatinine should be monitored. Okay, so it's important to keep them under follow-up after discharge. And especially by 2 months after an AKI, you should get a fair idea of how much function has been recovered. If recovery is incomplete, it's important to tell this patient they're likely now proceeding towards a chronic kidney disease. All right. So just a couple more things, some important differentials. When someone comes to you with a complete anuria, there are some things you absolutely have to rule out. Make sure you have ruled out a bladder outlet obstruction or a bilateral ureteric obstruction due to stones. Other uncommon causes are a rapidly progressive GN, thrombosis, and a cortical necrosis. Usually there'll be a much longer history for this. So this is so important to rule out. Okay, there are very few differentials for anuria. So please make sure that you look at these. Okay, then there is something called pseudo-AKI. This is simply drugs which interfere with creatinine secretion. Trimethoprim and cimetidine are important causes. So for example, we often see this in patients on Septran. So you would find that the creatinine would increase, but it's not because they have a kidney injury. So it's important. That's why drug history is often important. The other cause of pseudo-AKI is if you use the urine output criteria in morbidly obese patients, you would diagnose them with an AKI simply because they were overweight and they would have a low urine output based on that. So that's another cause for pseudo-AKI. Okay. These are just questions to test your knowledge. 35-year-old male with a weight of 60 kgs, no known comorbidities, presents with an acute febrile illness. You can see that the blood pressure is low. You can see the urea, creatinine, WBC count. When the patient comes to the emergency department, there's only 100 ml of high colored urine, and this is the ABG. So the first question is this AKI? Okay. Based on this information, remember we have only one creatinine value. We know that this is not a normal creatinine value. So this may or may not be an AKI. Okay. What tests will you order next? From this, you can easily make out that this patient definitely has a pre-renal insult because the patient is in shock. All right. From the urine, you definitely know that already the urine is getting concentrated. Okay. So at this point, you may want to, of course, look at the etiology, what this patient has. You have an idea of the electrolytes. So this patient is acidotic, the lactates are high, potassium is tending towards the higher, higher limit. It's important to get a urine analysis. That may be the single most important test to order right now because it'll confirm whether the patient has an ATN or pre-renal. So in a pre-renal urine, the urine is bland. But if you saw muddy brown casts in the urine, that will tell you this patient actually has an ATN. That is a more severe form of injury. Okay. Your priorities at this time would be to push up this blood pressure. If this patient is an acute febrile illness and is septic, you may have to start antibiotics. Do everything that you would normally do in the sepsis bundle. And of course, in terms of monitoring, like I said, it's important to monitor the electrolytes, the urine output, and all indicators of their volume status. So to summarize, we use the KDIGO criteria to diagnose and stage AKI. Then we use history, examination, and labs to tell us what is the type of AKI we're dealing with. When managing an AKI, it's first important to rule out a pre-renal AKI. Once we have replaced volume and the patient is not responding to volume, this is now volume unresponsive AKI, do a furosemide stress test and proceed to early renal replacement therapy if they fail the stress test. Once the patient is established as AKI, you need to monitor intake and output, their weight, creatinine, electrolytes, and look for any features of volume of fluid overload. Avoid any insults during recovery, and even after discharge, regardless of whether the patient has completely recovered or not, you must follow up all such patients for hypertension, proteinuria, and chronic kidney disease after discharge. Thank you.